You are listening to Preconceived, where we examine the preconceptions that shape how we view the world and the paradigms by which we live our lives.
Hey everybody, I'm Zale Mednig and welcome to another episode of Preconceived. A year into the pandemic, almost everyone knows someone who's tested positive for COVID-19. While the emphasis is rightly focused on the mortality rate, there is another side of COVID that is perhaps less talked about: recovery. While many do recover quickly, there's also a large proportion of people who are suffering from longer-term symptoms and require ongoing rehabilitation weeks to months after diagnosis. In fact, the morbidity of this virus will unfortunately affect the physical well-being of some of those affected for years to come. So how exactly is COVID impacting the lives of those who've become sick from the virus? And how can society best support rehabilitation efforts? I'm joined today by Dr. Ali Rendely. Ali is a physical medicine and rehabilitation physician at the University Health Network's Toronto Rehabilitation Institute. She also works as a sports journalist and has reported for various television and radio stations in this capacity. Currently, Ali works as a musculoskeletal and sports medicine physiatrist with an inpatient and outpatient practice and a special interest in COVID rehabilitation. She advocates for rehabilitation and related topics as a freelance health journalist, and she is the host of the medical education podcast, MSK Matters. So, Ali, welcome to the podcast.
Thanks so much for having me. Excited to be on here.
I'm excited to have you here. It's a really interesting topic today, and it's very apt, and it's almost deceivingly a preconception, I'd say. When we initially were chatting about this episode, in retrospect, I'm almost a little embarrassed because you sent me some ideas about it and talking about COVID rehabilitation. And I said, I wonder how relatable that is to people. And that reflects absolutely my own ignorance about it, because like a lot of the general public, I think I look at COVID as this thing where we've been focusing on mortality rates, obviously, which we should be. But we often don't really think about what about the person who gets COVID, recovers, and then actually has to go through recovery. Because yes, for some people, you're infected, you might be asymptomatic, or you might have minimal symptoms, and then it's kind of like a bad cold. For other people, that's not the case. And that's a whole different side of COVID that a lot of us haven't really considered. So tell me about the other side of COVID. And I'm glad that we're doing this because I don't usually talk about my own ignorance about a topic right off the bat, but I know I was ignorant about it, and I imagine other people were too.
You're definitely not alone.
Thank you.
I think that's the black box of rehab in general. People have a stroke, people have a heart attack, people get cancer, people have an amputation. And we think of their acute care stay and what that looks like, the immediate treatment, surgeries, interventions. But there is a whole world, and then the rest of their life that goes on that requires rehab. And the goal of rehab medicine is to really improve function and quality of life. And so when patients have COVID, have survived COVID, be that from a hospitalization, an ICU admission, or surviving it at home, they still require that ongoing rehab, sometimes for weeks and months. And as we're seeing, that might go on for years. We don't have that data yet, but there is a long-lasting symptoms that we're already seeing a year plus into the pandemic. And what that looks like for each patient is a little bit different. So part of my job is to find out what symptoms they're still having, but more importantly, how that's affecting them and affecting their life, and what they're not doing that they wish they were doing, what they want to get back to. Is that work? Is that school? Is that activity, specific sports? And how can I help them get there? So what organ systems might be involved, and what investigations do we still need to do, or how do I coach them through that rehab process? And I must say, I'm not alone. I am a physician, but this is a big multidisciplinary team that we use as part of rehab. So is it more physical function? Do we need a physiotherapist? Are there some problems with fatigue, energy, brain fog, thinking concerns? Do we need an occupational therapist? Are there swallowing issues? People still having changes to their smell or taste? Do we need a speech language pathologist? Is there depression, anxiety, fear? Do we need a psychologist involved or a social worker? So it's a big team activity that requires dedicated individuals for different parts of the recovery plan.
So how common are we seeing patients who've had COVID who are actually having issues that require some form of rehab in any capacity?
That's a
And
great
obviously that's really tough to answer because the statistics on this are quite fresh.
Yeah, that's a great question. And depending on when people are listening to this, this already might be outdated because data research studies are coming out faster than I can keep up with them. And trust me, I do a lot of reading on this. The
And we're
CDC
chatting in end of April for those who are listening, because this will probably won't air for a few more weeks.
And the CDC is using this post-COVID-19 condition. And so there's many terms that you'll see. That's the one the World Health Organization and the CDC are using. And they're quoting their numbers as anything greater than 4 weeks. So your frame of reference is also very important. So what they're saying is 20 to 30% of patients will have at least one ongoing symptom 4 weeks into their recovery process. Other studies are quoting about 10% at 3 months. I've seen everything range from 2% to 89% in certain studies. And that just speaks to the variability of the research right now. So, how many people are in the study, the severity of their illness, and how long out we're talking. Is it 2 weeks, 4 weeks, 4 months, 6 months, 12 months down the road? So, I'd say on average, 10 to 20 is probably the best guess right now.
I mean, that's not insignificant at all,
Not at all.
especially considering the number of people who have just been infected with COVID, right?
Yeah, worldwide, this is going to affect millions of people, and we don't even fully appreciate or understand what the rehab needs are going to be for the next 5-10 years down the road.
So when you look at people with COVID, do you kind of break them down into different categories of the ways people can recover, maybe mild, moderate, and advanced cases, and what that means for the long term?
Definitely. So I think when we're thinking of the infection itself, we think of those mild patients that were treated at home, tested positive because they maybe had contact or had some very uh, insignificant at the time symptoms, all things considered. We do also have patients that test positive but are completely asymptomatic, might be a little more tired on retrospect, but otherwise had no idea. We have our more moderate symptoms. So those are the patients that go into hospital, might require a little bit of oxygen or some steroid use, things like that, antibiotics if there's some pneumonia associated with it. And then our more severe cases that are in the hospital and require an ICU admission. But what we don't really have a good handle on right now is how to categorize the diagnosis, because the severity of illness that we're seeing initially is not necessarily correlating or predicting who is having those longer term symptoms. So I've seen patients in my clinic that technically never had a formal diagnosis of COVID because they were so early on in late March, early April of 2020 that testing was not as available in Canada where I practice as it is now. So now anyone can get a test at any time. We're not limiting people, but early on we were being very strategic about who could get a test based on initial supply. And patients will describe what was happening to them, but they actually never had a positive COVID swab. So there's also a category of people that aren't being included in this research because they technically never swabbed positive. But some of those people managed at home just fine, and now 6-12 months down the road are still having lingering symptoms. So mild cases do not preclude you from having ongoing rehab needs.
So it's not just those people, which I don't think a lot of people would realize, who've had severe COVID symptoms, who were in the ICU, who were taking time to recover. It could be somebody who basically had something akin to the common cold that they felt symptomatically, but then it's just lingering in terms of these symptoms, which we'll get into what those are. But that's a bit surprising and a little bit unnerving probably for people who, and maybe a little bit comforting to people also actually, who might have some validation in that, because there's probably not a lot of validation for people when they say, I had COVID, and then they're saying, I'm still feeling kind of fatigued, or I'm still feeling ill 6 months later. Some people probably look at them and say, what are you talking about? You barely had COVID.
For sure. And I hear this a lot from patients. And I think validation that we believe them, that their symptoms are real, even though I can't always explain them. I can't explain why some patients are having symptoms weeks to months out and other patients had mild, moderate, or severe disease and are doing just fine after their recovery. It's the research to come is going to be very interesting, but right now we just don't have enough data. And I tell my patients all the time, I'm learning alongside you what it means to recover from COVID-19. And I'm doing my best to stay up to date on the information that's being uncovered. But right now, what we can do is treat the symptoms that you're telling me are most bothersome to you, even though I can't necessarily explain the pathophysiology or the reason behind all of it.
So Ali, what are some of the main symptoms of COVID? What are we talking about when we're, and granted, I know it spans a lot of different things, but what are the most common symptoms we can start with that people are still expressing months after COVID?
Yeah, I like to think of them in a few categories. So I think of our musculoskeletal system, so our bones, joints, muscles, how we're moving. And I'd say overwhelming fatigue is one of the major symptoms that comes with that in terms of just not really being able to use your body in the same way. So deconditioning or loss of muscle mass. And that can come from lying in bed or lying in a hospital bed for a prolonged period of time, but just a decrease in your mobility or your ability to move around. So that I'm seeing much more than specific areas of pain or reduced range of motion or things of that nature. Then I'd say we think of the heart and lungs. So breathlessness is a big one that I'm seeing. Patients that were active, young, healthy, and are now on supplemental oxygen, or they're going home from hospital needing ongoing oxygen support. And so they're still having kind of desaturations in their oxygen level with any sort of movement or activity. And so that's also limiting their activity tolerance. And from the heart perspective, we're seeing a lot of abnormal increased heart rate inappropriately. So structurally, the heart is okay. We look into the heart function and it's doing what it should be doing, but it's beating faster than it should. And we're not entirely sure why that's happening. We think it's related to the autonomic system and autonomic dysfunction, but unclear exactly if it's inflammatory or how that's happening.
When you're talking about these, I'm pretty sure you're not just talking about people who are older. You're talking about younger people too, right?
Yeah, I've seen anyone from mid 20s to in their 80s and early 90s. I haven't seen any pediatric patients. That's outside the scope of my practice. I haven't seen any teens yet, but I'm seeing 20-year-olds going home on oxygen from hospital, whether or not they were intubated or not, needing that for several months post-hospitalization.
Wow.
Yeah. But I will say this isn't all doom and gloom. I do see patients slowly come off the oxygen, return to activity, get their breathlessness back, get their mobility back, be able to add things in slowly. So that's part of what I help them with. But we are seeing that these are some of the initial symptoms that do tend to linger for several weeks to months later. And then there's two more categories that I think of. So then our neurological system. So that's our brain and our nerves. And we are seeing that brain fog that people are talking about. You hear a lot in the news and the media. That can be anything from changes to attention, memory, kind of difficulty focusing, like following instructions, to more specific, like nerve injuries, speech and swallowing dysfunction, or hearing and vision issues. So it can target some of our nerves. And then just the psychosocial. So we are seeing low mood or depression, anxiety, post-traumatic stress disorder, or ICU survivor guilt. So it depends on the patient's prior medical history and their specific circumstance, but we are seeing, I'd say, probably close to 30% of our patients need some sort of psychological support or counseling to help cope with these symptoms.
That's a pretty staggering number. Again, I think a lot of this is probably surprising to people. For the brain fog and for the fatigue, which I think are two symptoms that could probably be discounted by a lot of people, and why I think it's good that this is validating for them. what are some of the things that when they come see you, you help them in their rehabilitation?
Fatigue is more than just feeling tired. So patients are going to sleep and waking up still feeling this overwhelming sense of an inability to do things. They just don't have energy. They're taking naps during the day when they were otherwise going to work all day. This is very new for them. So what I try and do is find out what's really important for them and how can we get them to do small things throughout their day that are important. And so we prioritize activities, we talk about pacing strategies, so taking breaks, breaking things into chunks, putting things on a calendar or a to-do list so you can cross them off or space them out into your day, writing things down. So if you live in a multi-room house or multiple floors, you're not going back and forth because you forgot something and using more energy. You're trying to consolidate your activity. So giving little tips, tricks, and strategies on how to conserve energy and pace through prioritization and list making, I find very important, but also limiting their energy to things they want to be doing. So we try and see if we can get them support from the community to assist with bathing or have friends or family help with meal preparation or groceries, things that they don't have the energy for, to allow them to use their energy for physical therapy exercises or getting back to walking, things that we know will be helpful for their recovery. So can we also enlist their support system to take on some of those tasks that they were doing for themselves?
And I guess, like you alluded to before, when you're looking at prognosis and saying, when is this going to go away? We're all kind of in the dark about this. But I imagine that the goal is one, rehabilitation to get you through this. And then two, some of it is just hoping that, as with a lot of diseases and infections, that time will take its course and help improve things.
Definitely. Time is our best medicine outside of exercise, which is my
I tell
actual favorite
I tell that
medicine.
to my patients too.
Time and exercise. Um, yeah, and as you know, physicians are terrible at being crystal balls, right? Like, I don't have a crystal ball to say your fatigue is going to end on this date and your energy is going to come back on that date. And what I can do is give you all the tools in the toolbox that I have to make life a little bit easier for you, to help guide your recovery, to give you the strategies and the best evidence from a rehab perspective, and then help troubleshoot anything that comes up along the way. But every patient is different, and every patient can cope differently with the symptoms that they have. So fatigue might be very debilitating for one person, and for someone else that might have fatigue, it's their nerve injury that might be more bothersome to them, and they're okay with the fatigue. So that's a really key part of rehab medicine, is we focus on the person. There's no one size fits all method to this. It's really what's important to that individual patient and how do I help them get back to the things that they personally enjoy doing. Not that I enjoy doing and their loved one thinks they should enjoy doing. It's really about them and their rehab and recovery process.
That's an important point, because it is really easy when you're looking at the same disease to treat it the same way every time, but it's such a multifactorial disease and it can have such uh, variable responses in people. So that's a key point.
Yeah, I'd say in general, the term post-COVID condition or long COVID is really an umbrella term. And we're trying to, or the research right now is trying to determine, is this a constellation of symptoms? Is it one pathological process? Is it multiple entities? I think we're still just getting to the surface of what's happening and trying to really define it better. The definition is still up for debate when you Google it and look into it further. So from that perspective, it's more important to validate the symptoms that your patient is having.
Talk to me a bit about some of the psychological consequences that you were mentioning before: anxiety, depression. I've even heard of survivor's guilt from people who have come out of the ICU. What do some of those things look like?
Yeah, so it is fairly complex, and I think we know there's a wide spectrum depending on, does a patient already have a diagnosis of anxiety or depression or another psychiatric illness that might predispose them to having another one or to exacerbating a pre-existing condition. And we know that when someone goes through a major life event, including a new medical diagnosis, there is a propensity for anxiety and depression. Maybe not a formal diagnosis, there's a spectrum of that. And so we can call that adjustment disorder. But to me, it's just adjusting, right? It's natural to feel overwhelmed. I think it's also important that we recognize this is the first time this patient is going through this rehab process. So to them, it is a never-ending tunnel and there's no light at the end. They don't know what this looks like. So spending time explaining to your patient what rehab looks like following a disease, any disease, is important because it's known to us as rehab physicians, but it's really an unknown to most people. So you can help with that type of anxiety. But in general, patients are really having a hard time accepting that these symptoms are ongoing. It's really debilitating to their life. They cannot do the things they want to do, and yet they're being told that they're quote unquote COVID recovered. And so we know like surviving the illness doesn't necessarily mean that you're recovered. We now know people have these lingering symptoms despite testing negative or no longer having active infection. Those aren't synonymous. And that's really important to remember. In terms of how long these symptoms are lasting, it's really dependent on the individual. We try and get our psychologists or our psychiatry colleagues involved early and often, trying to help patients with both psychological counseling or medications, depending on the situation. And then it also depends, as you mentioned, there's ICU survivor's guilt. And a patient spending a prolonged time in ICU and then in hospital and then maybe inpatient rehab is completely different than dealing with a patient who was at home, maybe supported by their loved ones. So again, that spectrum of disease and context matters. But we are seeing about 1 in 3 patients having some sort of psychological consequence. And as you mentioned, that's not insignificant. And we know mental health resources at the best of times are limited.
Yeah, and psychiatric illness already is very stigmatized, as you know, and most people probably would agree with. So when you take that psychiatric illness and superimpose it on COVID, when most people are saying, oh, but I know a lot of people who have had COVID and they're fine, you should be fine too. The lack of a full appreciation of psychiatric illness, I'm sure, is exacerbated in cases where patients who've had COVID are then undergoing psychiatric distress or any form of psychiatric illness, or even if it doesn't meet criteria for psychiatric illness, just not feeling psychologically right. And that's why I think this is so important, because it's validating, or hopefully it's validating to people that it does take a different toll on every person. Everybody's baseline is different too. So I hope this brings more awareness to psychiatric illness in general, but I also hope that it helps people who are suffering from psychiatric illness in the midst of COVID get a little bit more empathy from people. That is probably much needed while they're struggling.
Definitely. I think we have to accept what a hard time this last 13 months has been for everybody. Losing a lot of our support systems, doing those social activities we're used to doing to cope with stress in our everyday life has been taken away from everyone. And yes, there's been more FaceTime video calls, but it doesn't replace in-person interactions, seeing your grandparents, hugging your loved ones. It's really tough. Add on top of that, maybe a pre-existing mental health condition. Add on top of that, COVID. It's really hard. So I do hope everyone is empathetic to everyone else. We don't know what's going on in the minds of other people. And I hope we see the day when mental health is no longer stigmatized. That would be the dream. But as you said, we hope this podcast brings hope to people and lets them know there are physicians out there that care, and get in touch with your care team if you're suffering, because there are ways that people can help you. And I don't want people to feel alone. It's a really hard time right now being physically distanced, but we don't necessarily have to be emotionally isolated or disconnected from those that could support us.
Absolutely. And it sounds like at University of Toronto, where you're doing your work, it sounds like it is a pretty interdisciplinary approach where you've got a lot of different prongs in trying to help people with COVID. Tell me a little bit more about the clinic you're working at and what, I don't want to say makes it unique, like it's a test to be unique, but what makes it, what you think are some of its strengths that are really helping patients?
For sure. I think it was the first multidisciplinary virtual COVID rehab clinic in Canada,
Wow.
from what I know. So I think it is pretty unique. And if not technically the first, at least one of the
So
first.
unique wasn't as bad of a word as I said then. Great. Okay.
No, I think it's a testament to our medical director and the head of rehab, Dr. Mark Bailey, who started spearheading this project early on. And by last summer, July or August of 2020, was already starting a multidisciplinary virtual rehab clinic for patients having symptoms bordering on, at that point, 6 months. So really early on, the UHN team identified that through their COVID clinics, they didn't know where to send their patients after their infection had technically cleared, but they still had all of the symptoms that I mentioned before. And it's amazing that they started collaborating with us at Toronto Rehab Institute, the rehab center affiliated with UHN. And then I was brought on because the numbers were overwhelming. Dr. Bailey was basically seeing patients on his own with a multidisciplinary team. So every initial consult gets seen simultaneously by a physiatrist, so a physical medicine and rehab doctor, a physiotherapist, and an occupational therapist. And then depending on the referral, a psychologist or social worker as needed. And now there's two of us seeing patients under the age of 65, so Dr. Bailey and myself, and we have a geriatrician who has a special focus in rehab who's seeing some of our 65 plus patients. I have the advantage of also being an inpatient physician on one of the wards where we accept COVID recovered patients who need inpatient rehab, so generally those that have been in ICU for several months. And regardless of their age, I will tend to follow them in this community, in this clinic, once they're discharged into the community for continuity of care, which as a physician is amazing to be able to see that longitudinal progression and get a better sense of how quickly some of these patients are recovering or not recovering, and hopefully gain some data over the next several months.
Well, it's undoubtedly great work you're doing and your clinic's doing. Now, it obviously this question is dependent on where people live. In Canada, we're lucky that we have a pretty good public healthcare system, but around the world, the States, our neighbors, and in a lot of places in the world, they don't have a system that is as public. What are the concerns globally for people who are trying to rehab from COVID, let alone just survive COVID? But what are the concerns for people trying to rehab from COVID when there are issues with having insurance coverage and having these huge costs that can accrue? Is that something that we're seeing around the world, that people just aren't getting the help in a lot of parts of the world and unfortunately probably won't? Or are there some examples of countries that have done a really, really great job at trying to expand their resources?
It's a great question. And I think even in Canada with our healthcare system, physiotherapy, occupational therapy, speech language pathology, none of this is covered. So even in my
Psychology is not covered as well.
psychology, yeah, registered dietitians who assist us tremendously post ICU and with muscle mass loss and trying to get calories back. Tons of our allied health practitioners who, quite frankly, I could not do my job without. On the ward, in clinic, I have so much gratitude for all of them. None of that is covered. So COVID or not, we are not at a good place with rehab in Canada. We need so much more funding from the government to support rehab. It shouldn't be acute care and home. This is leading to that morbidity. If our workforce aged individuals are being forced out of the workplace because they can't get the rehab that they need for months or years on end, that is a huge problem. If those individuals cannot work and then end up on EI or some sort of other subsidized funding, we're creating a huge problem by not looking to the reason this is all happening, which is rehab. So at last count, I understand that Canada had 7 rehab multidisciplinary post-COVID sites that were being funded by the government, including the one at UHN. I'm not sure if that has grown at this point, but as of last month, it was 7 for our entire population, which will not cut it.
And that's scary because, as you say, Canada is probably an example of one of the countries that has a pretty good public health system, and Canada's struggling. And like you pointed out, a lot of things in Canada aren't even covered. So imagine if you're living in a country where even less is covered, which is the case for a lot of countries.
I know the UK has done a great job. They've put out a ton of research on post-COVID. The National Institute of Health Research actually just released a big document 2 days ago on some of the post-COVID rehab that's going on. And I believe they funded 80 clinics to be opened across the UK. So they are an example that I would look towards. I do follow some physiatrists on social media from the US, and it seems like certain hospitals have started to do COVID rehab. I'm not sure the funding model from them. My guess is, like most things in the States, you've got to pay for it. But I do think it's becoming a niche subset of rehab medicine because it's going to be here for a while and it's within our skill set. It's a new virus, but it's not new rehab, if that makes sense. I can't always explain, as I mentioned, the pathophysiology because we're learning that, but I can guide the rehab because it's the same rehab principles that I use for other disorders.
And I think you've done a really great job of explaining that. You mentioned earlier it's not all doom and gloom, and I don't think that that's the message that. I mean, maybe it is doom and gloom to some extent, but I don't. I don't think that's the primary message coming out of this. I think it's that there are ways that you can help yourself and get help from the medical system, and really, and I know I've said this a few times, but it's that validation that this is real. And if you're listening at home and you've had COVID and you've been feeling a bit fatigued, but you've been afraid to maybe say anything because you're thinking, I'm fine, I didn't have it bad, I'm lucky that I survived COVID. You don't need to be ashamed to admit you're still having problems from it. That's the course of the disease, and there's help that you should go out and seek and get. And I think that the work you're doing is really important, and I think that that's really the main message that I hope people take out of this conversation. Do you have any other final thoughts you want to leave people with on this chat, Ali?
Yeah, thanks for that. I agree. I think it's really inspiring to see some of the patients, how far they've come. And I just hope patients can applaud themselves each day for what they do accomplish. So for some patients, that might be getting up, getting dressed, making their bed, and that is something they didn't do the day before, and just validating to themselves those small accomplishments. It's easy to get lost in what you can't do. And if you are someone who is going through these symptoms long term, maybe take a piece of paper, write down one thing that you're thankful for each day or that you're happy that you achieved. And by the end of the week, you'll really see that you've done more than you think. So congratulate yourself on your recovery. And even if it's not as fast as you'd hoped, give yourself the time that you need and reach out to a healthcare provider to help guide you how you might be able to improve with a little bit of guidance.
I think that's very well said. Ali, where can people learn more about you, learn about your clinic?
Yeah, so I'm pretty active on Twitter at Rendely and reach out. I'm happy to chat. The clinic that I work at, you can learn more about us through the University Health Network Toronto Rehab Institute website, Twitter page, LinkedIn. We're all on all the socials.
I'll put all that in the episode notes so people can be sure to follow you on socials and get all the information they want. Ali, thank you so much for joining me. I really appreciate you being here.
Thanks. This was great.
Dr. Ali Rendely, I'm Zale Mednick. I hope you've enjoyed this episode of Preconceived. Have a great day.